the idea of the patient care tower. It's a little bit difficult to understand when we talk in medical jargon as to what procedures we're doing. This is looking into the future. This is the future of medicine. This is hopefully going to get our specialists here, keep them here, and get more to stay, as Dr. Bradbury's on it, and others are going to talk about the design of the patient care tower. We hope by the end of this evening you'll be convinced, as we are, that this is a good idea. That we do need to stand up together and tell the government this is a good idea. We can't waste any time. We've got to do it now. Thank you very much. Dr. Bradbury's on, Medical Staff Chief.
Yeah, my name's Dr. Bradbury's on. I'm an emergency physician now. If I had known I was a quarterback when I was family practice, I don't think I would have changed. Nobody told me that. I've been around here a long time. First came here in 1980. My job is really quite simple, is to tell you folks what you're going to get for $300 million. We're most of us here are amateurs. So if you can't understand what we're saying or talk too fast, boo or scream, we're quite informal here. So I just found out that my memory is not as good as it was. I just talked to Mr. Ken Jagger, who was one of your previous, now worked with the, what's the word, Medical Foundation. Before that was chairman of the hospital, and we had a hospital board. And he informed me that I was around when this tower was first started. And I was actually involved in what happened. It is an interesting story in that how this project came. A number of years ago, Ken and I disagree on how many years ago, this project came up, and it came up because we were amalgamated with Okanagan at that time, and there was a move to move ambulatory care to across the street, and we didn't think that was a good idea for a number of reasons, and that's when this first started. I think it's closer to 10. Ken thinks it's 5, but I think his memory's failing. So the first thing to look at is the title, ambulatory care tower, outpatient. You know, what the hell does all that mean? It's simple. It's the procedures that you go to the hospital for, that you do, and then you go home the same day. And it involves diagnostics, it involves some surgical things, a number of other things like that. I must admit, why this philosophy came out, this is an extensional hospital, whatever you want to call it. The philosophy behind this is a bit different than just building a bigger and more hospital. It's to try to make it more efficient. The emphasis on this was, number one, outpatient service, ambulatory care service, whatever you want to call them. And the reason for that is because that's what we do good. We're not going to have cardiovascular surgery here. We're not going to have neurosurgery. But we do first-class referral surgeries, and we do more and more of it outpatient. And this is where medicine's trending toward it. The other we put in here, we looked at the building, and what's the oldest thing there? The oldest part of the building is the surgery. Those ORs were built before, I would say most of you were born, but that's not true. Most of these guys, or all of these guys that were born, Ken and I, we were around when the hospital was built. So this is outlay. We'll go quickly through the slides. If it's too long or boring, boo, and we will move on. And I'll try to give you an idea of how the planning. So the conception was, let's fix the ORs, get new ORs, at the same time, try to build a tower where we can do more things as an outpatient. So maybe I've got Janice here at the slide, because I can't do two things at once. I'm dressed like this because I'm supposed to be at work. I'm playing rookie. So bear with me. I'm going to point here. You can see where the old slide we have now.
Can't hear you from the back.
First time I've ever been confused and not being able to heard. So there's three parts of the hospital. The original part of the central pavilion, which is we have the ORs in, that was built, started in 1951, finished in 1953. Asbestos city. The second part is what we call the south wing, which where most of the beds are, and that was built in, that date there's wrong. I've been here, 1969, started in 69, finished in 1971. And you have Dr. Tom Ashton there, who was involved in that, and got a name on a plaque. And the newest renovation was the one done in 1987, finished in 1989, which is what we call ambulatory care, emergency, and ICU. And if any of you have gone to the hospital, you realize that the ambulatory care was built, it was outdated from the day it started. I was involved in that plan. They ran out of money, so they cut 25 feet off the width of the building. So they lost a hallway, all the size of those things. We quickly outgrew that thing. You can look at, if you look at the only part of our hospital that probably is 21st century, that happens to be the ICU. And I think that has a lot to do with Tom Ashton getting everything he wanted 25 years ago. But it does show you can plan to have something that's going to last for 25 years. So that's what we have now. One next slide. This is what the concept of what it's going to look like. In ambulatory care, this would be off of Government Street. Next one. Okay. Do we have one this covers the whole top or not? Can you go back and forth? Is that good, Janice? Okay. Do we have an overview of the whole property? Maybe to go back to that to explain the property then. Not really. Not as good as you think you are, Janice. What I'm trying to show you is maybe give me the one that we had traditionally at the beginning, or what we have now, to show where it's going to go. We have a really good slide for that. No, the one that showed what we have now, the old hospital. That's the one. So I'll just show you. So that area is where we want to put the new tower. It will attach to the old building. Now we can move on to the other side. So what we decided was that when you come to the hospital for ambulatory care stuff, what we describe as, you will go in this entrance. You won't go in what is the old entrance. That will be the main entrance of the hospital. When you come in for anything else, daycare, you go into this entrance, a separate entrance. Go ahead. Keep going. So we have a number 4. This is the basement floor, which actually is like a walkout basement that looks out at Boat House. And the bottom, we're going to have some medical school, which one of the other physicians will talk about next. This is the main floor. So if you go over where it says public concourse drop-off, that's where we saw you drive in there off of Government, you go in here, and this corridor would go all the way through what now is where the MRI sits sometime, to the south doors, and out the main entrance. So you can see there's a traffic flow right through there, so you come in from there. Next slide. So this is the same thing, only showing in more detail what's going to happen on the first floor. So first floor, you come in, and what's the change of this concept is that right now, if any of you have gone for any tests at the hospital, you might have to go to 5 different places to get it done. So the ground floor is basically what we call medical services. That's the doctors that do things, don't cut you. And diagnostics. So this proximal point here would have things like, if you came for a plain x-ray, this is where you're going to go. If you come to have a blood test, this is where you're going to go. If you're coming to have a stress test or see a cardiologist, you go in this area. If you're coming in to have a blood transfusion, this is the floor where you go in. And the concept is you come in at the bottom there, and then you have one receptionist that fills out those papers you get for all the tests you're going to do, not just going to a different place of the hospital for everything. And then a common waiting room with different areas, much like they have at the airports now we do. So this would be the medical end of it. And one floor up. Color's not very good. This is with the part to real mind. This is the surgical area. So this is one floor up on top of what we had. Again, you park in there and come in here this thing. This is on the second floor. The parquet is attached to it, so the parquet on level 2 would come off at this door, as you can see in the middle there. So you go in, park your car in the parquet, or come in, or go to the front door and kick out your husband and go off and do what you want to do while he's getting stuff done. The same principle, you come to the top, there's one receptionist for all the kind of surgical procedures you're going to get. In the front, it may be simple as taking a mole off for a lump and bump. The more clothes you take off, the more you get farther in there. That's an important part. No one likes to have their butt hanging in the wall out of the door when they're going to have someone stick something up it. It wasn't meant as a joke. I actually designed this. Having been a patient and showing the world my butt, I don't want to do that. So in the back is things where you do endoscopy, gastroscopy. That's where they stick those tubes up and down all the little orifice to tell you there's nothing wrong with you. And in the back is the big money thing, the medical device reprocessing. You know, what the hell does that mean? That means that's the most important part of the hospital. That's where they clean the things that they cut you open with and stick in you. So if that isn't working, then you don't want to go to that hospital. And the one you've got now, it was made in 1950-51. So that's the that would supply all the clean service for all the hospital medical instruments. And the big ticket items are this and the ORs, which are the new ORs over there. Again, to make this run better, what's happened is the white area way to the right now, if you go for daycare surgery or endoscopy, for all these procedures, you go to different little hallways in the hospital, literally. Right now, it's designed that both the after surgeries nurses and the nurses that do endoscopy would work in the same area. So you can see those are stretchers. So what happens in hospitals in the morning, everybody goes to the OR, which takes hours, and they do things like outpatient stuff that takes half an hour. So the flow of the patients would be, more of the patients that are going to come home will be gone by noon, and then at the same time when the people start coming out of the OR to go back to they can change those beds back and use those stretchers again for that person. It's a bit confusing, but what I'm really trying to say is we can be more efficient, get more things done, and do a good job with it. Next floor. Next, guys. So is the government. This is the mechanical floor. Just reminds me that the guys that came and did this were from the States, and they specialize in basically doing ambulatory care buildings, not hospitals. In the old days, almost around the mechanicals were thrown in the basement. That mechanical floors, they can stick in anywhere. Now, next. So this doesn't exist because you're not allowed to have non-space after the issues in Vernon. So in the old days, you used to build a hospital, and you're smart, you put a couple extra floors on it for future development. Basically, the government minister, in fact, has told me that's not going to happen again because of what happened in Vernon. They want it open the next year, not 20 years down the road. So, I can't take credit for this. This is a plan to use outpatient clinics like oncology, wellness, which are basically office-type things on the floor above that. Next slide. It just happens that that is a perfect match for 30 beds. Lo and behold. And so we are using the space which meets the letter of the law with the government, but things are going to change. Someday they're going to need new beds, believe it or not. And this project is sitting with 2 state-of-the-art beds which are available for that. All these concepts, all the things I've shown these floors, the hospital we have now, and some of you have done construction understand there's retaining walls. None of these walls are built in stone or say literally. All these are modulars now. And it's built on a modular, what is the size of a workable space. So it turns out when you're building the construction, it turns out that the physicians are bigger, the patients are bigger, you need a bigger space. It's a very easy thing to change that space to make that room bigger or to make it smaller. In other words, it allows flexibility not only in the planning now, but in the changing when we're building it, and then again when we change in 10 years, no one's going to need medicine. So this project has a lot of flexibility in it. Run out of time, keep going. Next one. Oh, this is my baby. This is a helicopter pad. I did request my own personal helicopter, but the minister didn't think that was going to go. He did agree, now the finance committee did agree that, why are we doing this? Medicine is becoming specialized. We don't do heart surgery here. We don't do a lot of things that. One of the standards of care of heart surgery, now when you have your heart attack, you come to our hospital and we give you some drugs and try to open it up. The standard of care, a lot of the world, in the first world is, they stick a little wire in there and open up the vessels. But you have to do that within time. You're not going to drive to Kelowna and get it done. Kelowna has that service now. They have 180,000 people. I'm not an economist, but it doesn't make sense to have a multi-million-dollar system there that only has an intake of 180,000 people for a few things. With my helicopter, I will give you a ride right to Kelowna and you will have your vessels opened up. Not to be. There is the avenue of things that we're receiving things, but I think in the future, we'll be sending more people this way. The government just has to catch up with my ideas. So that gets us to this, and that gets us to why are we here today? We're here today because we've spent many years, about $800,000 of your taxpayers' dollars to get to this planning stage. Once this is done, it gets packaged up and it gets sent to the government. Then the government goes to the different steps of government, and right now, your cabinet, your treasury board, is sitting this week deciding whether they're going to pick this project or not. That's why all this has been speeded forward and done like that. Right now, your government, my government, your kids' government, maybe, I don't know, but whatever government's involved in this, this is going to, it doesn't go ahead now, it's going to get backlogged and it'll go along forever. So that's why we brought it to the public eye now. We need to hear it now. They need to make a decision on this. Some of the others will go into the group of why we do this. I've been here 30 years, and I've been to other hospitals. I worked in every hospital in this region except Princeton. Now, that doesn't mean I can't hold the job, but I have worked in all these different sites, so I know them, and I've been around a long time. You know, this hospital you have here, the positions you had here, some of them weren't born when I started. I'm the chief of staff, and I fill out credentials. It's embarrassing when their graduation date was before they were born. You know, but it is happening. They come to here because we have a group that works together. Administrations work together. You've got nurses here that work down hard and run short a lot of things to make these things work. This establishment, whatever it was, if you look at the books of the Penticton Hospital, it's come close to or balanced the budget in the last year, way above anything else in the IHA, I would bet you anything else in the province. And unfortunately, we came to the conclusion why we've gone political like this is because you discovered doing it properly doesn't guarantee that they do not reward success, they reward failure. In other words, we need to have the government wake up and start rewarding success, because that's what we are here, successful. With that preaching, I will quit before I get pulled off the stage. And I'd like to introduce... For those of you who don't understand medicine, as emergency physicians, we're supposed to do it all. But in actual fact, if it wasn't for the specialists like Sarah, they're the ones who every day save our ass when we don't know what we're doing. So I'd like to introduce the ass saver here, Dr. Sarah Roker.
I'm Dr. Sarah Broder. I'm a respirologist and a general internist, and I haven't been here nearly as long as Brad has. I've only been here for 15 years, and I've been part of this development of this tower for about 10 of the years, and it's gone through 3 renditions during the time that I've been here. So why is the ambulatory care tower important to me? To me, it represents the future of where healthcare is going to be in Penticton, and it's going to be the future on multiple different levels. What I see when I look at this tower is what I would call one-stop shop. So patients will come in, they'll drive in here, be dropped off here. Luckily for me, there is definitely a coffee shop here because that's where I'm going to be working, and I always tell my patients when I'm done with them, I'll see you at the coffee shop. So they're going to walk in here, they're going to register over here, and they're going to be able to get all of the standard outpatient diagnostic services that happen at Penticton Hospital, but it's going to be in one small contained space. It's going to have outpatient radiology, the lab for bloodletting, it's going to have all of diagnostic cardiology, the respiratory department, and outpatient neurology. And right now in Penticton Hospital, these departments are scattered like seeds in the wind over our campus. And it is a problem. This just recently came to me in the mail. This is my patient profile from the BCMA. And what you're going to see here is this is age going up on this side, and you're going to see my patient profile is that I see the majority of my patients are 75 and above. And the black dots here are the median for British Columbia, who I'm compared to, being other respirologists. And you can see that my patients are way older than the standard patients that people see. And it's similar to everybody else's practice here in Penticton. And my patients have what I call the alphabet soup of problems. They've got high blood pressure and diabetes, and they've had previous heart attacks, and they've got COPD. And when they come to see me, this is a pretty standard person that comes to see me. And often they're pulling a tank of oxygen. It weighs about 15 pounds. And these guys are short of breath. And when they're coming to see me, I'm trying to figure out, is it their heart? Is it their lungs? Is it deconditioning? What are the problems that this person has, and what can I do to help make these people better? So when they leave my office, they get sent to Penticton Hospital. And this is the current what I would call campus of Penticton Hospital. And just to orient you, because it took me quite a while to figure out this floor diagram, Over here, this is Carmine Street. This is where Brad likes to hang out in that emergency department, okay? And this is that parking lot that we all are really angry about, that we have to pay for parking. All right? And my patient, this is really only $1 a day, guys. Come on. Like, I grew up in Toronto where you're paying $20 for the day. So it certainly doesn't get me all that upset. All right, so you're
that's
paying
$1 an hour.
here, and you
$5
then
a
have to
day.
walk in, and there's 4 standard tests that people walk out of my office
Don't forget to
requiring.
change.
And they're going to walk in here, and they're going to need to have some blood drawn, which is going to be over here. It's about 200 meters to get to that spot from the parking lot. And then they're going to need to go all the way down this corridor to the cardiology department, because they're probably going to need to have either an ECG done or an ultrasound of their heart. They're going to need to go back down this hallway, which is another 300 meters, all the way over to the radiology department to have a chest x-ray or a CAT scan done. And then eventually they have to be able to find this elevator here, and they have to go up to the 3rd floor and down another hallway, which is about another 200 meters, in order to have their breathing tests done. In total, my patients need to walk about 1 kilometer to get 4 standard tests done. And for them, this is like the bloody Ironman event, all right? And they are so exhausted, not just that day, they're flattened into the next day. And this is the reality of what our hospital is like. Our hospital was built in 1951, and we have been doing Band-Aid solutions for problems. Our hospital administration, Lori, we thank you, have done an amazing job of renovating our hospital, and the foundation, Janice, has done an amazing job as well of making creative solutions for these problems. But there is only so many times that a place can be renovated before you run into troubles. And right now, we can't renovate anymore. Susie, who is head of the lab, she has equipment that she wants to buy, but she can't buy it because the only place she can put it is in the morgue. All right? And my friend David and Tom over there, those guys, when they get to report your ultrasounds, do you want to know where they're doing that? It's in a closet that used to be where the coffee machine was. This is ridiculous. Now, my friend Stacy is not here today, but she's head of, or she was previously the head of radiology, and her pet peeve has to do with diagnostic mammography. So recently I had a breast lump. Well, most women over the age of 40 have probably had one, and I needed to go and have a mammogram done. And then I needed to go through 4 more waiting rooms with my gown on in order to have the diagnostic ultrasound done and possibly a biopsy. This does not preserve our patients' dignity, and we need to be working on dignity and privacy so that we do not have people like this who are going down the corridors. The other thing that is near and dear to my heart with this building is that within this building there is going to be shared outpatient clinic space. Right now, your pre-operative assessment clinic has changed locations so many times, I don't even know where to send the person these days. There is also primary maternity clinic, the rapid access respiratory clinic, the cardiology clinic. All of these clinics, the CAS clinic, I don't want to miss out on my orthopods, are very high utilizers of all of these diagnostic services. So when you come in for your appointment and get seen right in here, you can walk outside and get all of your tests done within 50 meters of where you went to go and see your doctor. Is that not an improvement for your life? Another thing that is near and dear to my heart has to do with the basement. The Penticton is not the home of the new UBC medical school. It's Kelowna, but we are going to be intimately involved in educating these people. They started 2 years ago. They're going to be hitting our hospital 2015, and they are going to need to have on-call rooms and places to sleep. They are going to need video conferencing facilities, and these are going to be state-of-the-art places for them. Currently, I don't know if you've ever noticed, but there is a set of trailers in our parking lot, and that's where our medical students get to sleep. This is going to be a major improvement for them. So you might ask, why is a bloody respirologist speaking out now? And I have to tell you that there are really 3 reasons why I'm steamed. The first one, Janice has already hit on. There's been $93 per person per year spent up in Vernon, and we've gotten a measly $22 per person. That is unacceptable. The second reason why I am completely and utterly steamed is that I hear rumblings. You should be happy. We got a jail in the South Okanagan. That's our capital investment into the area. Well, I say that's ridiculous. Those people are going to be taking more healthcare services, and they are not taxpayers in this area. They are not putting anything into our community. If I knew that I was going to get either a jail or an ambulatory care clinic, which one are you going to choose? I think I had one more point, but now I can't remember it. So I think I'll stop there.
Geez, Sarah's so good I feel embarrassed. I'd like to introduce you to our neurologist who's going to speak to a few points about that. And Neil is one of those guys that was born after I graduated. I could have delivered him.
Hi. So my name is Neil Davidson. I'm one of the 2 neurologists in town. If I say anything that bothers you, then my name is Dr. Dave Novak. Please refer all complaints to the college. You're not here, are you? Okay, good. So I've asked me to speak about neurodiagnostics. So neurologists are responsible in large part for looking after your brains, which you're all using, okay? And they're kind of important. In our population, over the next year with the population studies, more of you will have a TIA or stroke than you will have a heart attack. So it's important to provide us with the tools that we need to do the job. We have EEG and EMG. Those are the wiring tests that we do on people, and we rely heavily on radiology's use of CT and MRI. I'd like to thank the community for the CT scanner that we have. It's excellent and does a great job and is our workhorse. But we also use MRI quite a bit. And it has become apparent that although an MRI has been repetitively promised, it has been linked inexorably to the appearance of the care tower, seemingly as a delaying tactic for its appearance. So if you want us to have the best tools so that we give you the best healthcare possible, given the size of our community, you need to support this project. These decisions are unfortunately about money and politics, and that's why you're involved. And I think you deserve the best healthcare possible. On a side note, I'd like to say that Brad has always criticized me for looking at ankle x-rays, so I'm really curious to see what happens when he flies you to Kelowna in his new helicopter. Anyways, thank you all for coming this evening, and thank you for your support.
Thank you, Neil. The next speaker is going to be Dr. Andy Hamilton. He's an anesthetist. That's the guy who hopefully puts you to sleep when they cut you open.
And hopefully I won't put you all to sleep tonight. So thank you very much for coming today. This is an amazing turnout. So as Brad said, I'm an anesthesiologist, which is what we call ourselves these days. But I'm also the medical director for surgery for Interior Health. And I also do a lot of work with the ministry and the BCMA, trying to improve surgical services throughout the province. So thinking of globally, our focus throughout Interior Health is to improve the experience for patients who require surgery. Waiting for planned surgical procedure is a big problem. And many patients have to wait too long, either to see a surgeon in the first place in his office, or to have the surgical procedure once it's booked. But I want to talk now about surgical services here in Penticton. Our surgeons and anesthesiologists, nursing staff and support staff do amazing work. And I'll tell you a little bit more about that later. But our operating rooms are past their time. You heard when they were built. They weren't built for what we're doing in them now.